Cardiac disorders in pediatrics. Now we'll be talking about outflow obstruction in a sick infant. These lesions include coarctation of the aorta, interruption of the aortic arc, and hypoplastic left heart syndrome. Clinical features are: in all of these children, they usually present sick with heart failure and shock in the neonatal period unless diagnosed on antenatal ultrasound. Management is resuscitate with ABCs. Prostaglandin should be commenced at the earliest opportunity. And referral is made to a cardiac center for early surgical intervention. First, we'll be looking at coarctation of the aorta. This is due to arterial duct tissue encircling the aorta just at the point of insertion of the duct. When the duct closes, the aorta also constricts, causing severe obstruction to the left ventricular outflow. This is the most common cause of collapse due to left outflow obstruction. Clinical features of coarctation of the aorta. Examination on the first day of life is usually normal. The neonates usually present with acute circulatory collapse at 2 days of age when the duct closes. Physical signs include a sick baby with severe heart failure, absent femoral pulses, and severe metabolic acidosis. Investigations on a chest radiograph, cardiomegaly from heart failure and shock. On the ECG, it will be normal. Management of coarctation of the aorta. This is the same as for all the children in this section with outflow obstruction in the sick infant. Surgical repair is performed soon after diagnosis. Now we're done with a coarctation of the aorta. We're looking at interruption of the aortic arc. So the features of this interruption of aortic arc. It is uncommon, with no connection between the proximal aorta and the distal to the arterial duct, so that the cardiac output is dependent on right to left shunt via the duct. A VSD is usually present. Presentation is with shock in the neonatal period as above. Complete correction with closure of the VSD and repair of the aortic arc is usually performed within the first few days of life. Association with other conditions such as DiGeorge syndrome, where there is absence of the thymus, palatal defects, immunodeficiency, and hypocalcemia, chromosome 22q 11.2 microdeletion. Now we're done with interruption of the aortic arc. We'll be looking at hypoplastic left heart syndrome. Hypoplastic left heart syndrome. In this condition, there is underdevelopment of the entire left side of the heart. The mitral valve is small or atretic. The left ventricle is diminutive, and there is usually aortic valve atresia. The descending aorta is very small, and there is almost invariably coarctation of the aorta. Clinical features of hypoplastic left heart syndrome. These children may be detected antenatally at ultrasound screening. This allows for effective counseling and prevents the child from becoming sick after birth. If they do present after birth, they are the sickest of all neonates presenting with a duct-dependent systemic circulation. There is no flow through the left side of the heart, no ductal constriction. So ductal constriction leads to profound acidosis and rapid cardiovascular collapse. There is weakness or absence of all peripheral pulses, in contrast to weak femoral pulses in coarctation of the aorta. Management of hypoplastic left heart syndrome. The management of this condition consists of a difficult neonatal operation called the Norwood procedure. Children who have complex lesions or are small for gestational age undergo hybrid procedures that are a combination of cardiac catheter and surgical operation. This is followed by a further operation, Glenn or hemifontan, at about 6 months of age, and again fontan at about 3 years of age.